Okay, good evening, all the aspirants present here. Today's topic is metabolic disease. It's a class 2, and the speaker that we have here is Dr. Vinod Jaiswal, sir. He is a consultant critical care at Medcare Royal Specialty Hospital in Dubai. Thank you, sir. So, you may take over.
Yeah. Good evening, everyone. Thank you for joining. Thank you for your time. Hope you are doing studying well. I don't know most of you where and what stage of MRCP you guys are. Part one, part two. Anyway, but I wish you all the best, and we'll begin our second session of metabolic diseases. The pattern is slightly changed from the last one which I took. Not much, but just marginally different. So we'll have questions and then explanation, then maybe some detail in the end, something. So we'll proceed. As of now, Dr. Nishi and Dr. Pratap, you are only there, right? Can you hear me?
Yes, sir.
Yes, sir.
Yeah. If you don't mind, if you can answer the question, that will be good. I think we have two only, so you can answer, no issues. If okay.
Yes, sir.
1 second.
Okay.
Yeah. So the topic this time I chose bone and mineral metabolism and hyperparathyroid. We'll try to cover questions and some relevant text on that. All right. 1 second. My screen is gone. Can you see or no?
So, the screen is visible.
Visible, huh? Okay. Okay, let's. 65-year-old woman has fatigue, mild confusion, and constipation. The lab results show calcium of 3, which is elevated, phosphate low, parathyroid elevated. Very simple and straightforward question. So, what would the likely diagnosis? You guys can answer, I think. Dr. Pratap and Dr. Nisha, right? You
Primary
guys,
hyperparathyroidism.
let's see. Yeah, so it's very straightforward question. Um, elderly women generally primary hyperthyroidism in elderly patients with parathyroid adenoma, hyperplasia, very common. Of course, classical is hypercalcemia, low phosphate, and PTH, increased parathyroid. And everybody knows this common mnemonic. Okay. We'll go to second question. A 58-year-old woman has persistent hypercalcemia. PTH is within normal limits. Phosphate is low, and vitamin D is mildly elevated. She's asymptomatic. What is the most likely diagnosis?
PTH secreting tumor. Sorry, the PTH is normal. Sorry, sir.
Yeah, PTH is normal. Yeah.
Sir,
It's a slightly tricky question.
it could be primary also because primary can have normal PTH also.
Exactly. So it's a primary hyperparathyroidism. So PTH can be normal, although it should be suppressed, but sometimes it is possible. And many times, even primary hyperparathyroidism and hypercalcemia present as asymptomatic or incidental finding. So it could be normal. Yes. Again, low phosphate and mildly high vitamin D support the diagnosis. The most important condition to distinguish between primary hyperparathyroidism and is the familial hypocalcemia. Okay. So in this, the main so PTH may be mildly elevated, but calcium excretion is very low. Okay. So the calcium to creatinine ratio is less than 0.01. This is the main diagnostic criteria for familial hypocalcemia. All right. Can we look at the other ones? Yeah. So if we look at the vitamin D intoxication, PTHs again will be suppressed and phosphate will be usually high. Tertiary hyperparathyroidism happens in long-standing CKD. Of course, PTH will be high in these cases with low calcium and high phosphate. Any doubt in between, you guys, you can ask. Okay. After the some questions, we'll go briefly over the pathophysiology of these conditions. Third question: 55-year-old woman with osteoporosis has calcium 2.4, which is normal, PTH 12.4, which is elevated, phosphate low normal. What is the most likely diagnosis?
Secondary.
Secondary hyperparathyroidism. Calcium is normal, PTH is high. Why it could be normocalcemic hyperparathyroidism? I think that was the answer. Yeah, normocalcemic hyperparathyroidism. Let's go back to the question first. Why it cannot be? You said which? Tertiary, right? Or secondary?
Secondary.
Yeah, secondary hyperparathyroidism happens due to different reasons of vitamin D deficiency or low calcium. In those conditions, it happens. Although here calcium is normal, PTH is elevated, and phosphate is also low normal. So it could be normocalcemic hyperparathyroidism, right? Any doubt?
Sir, in secondary, calcium should be low. If it is normal,
Yeah,
then it
that's the reason, no? Correct. Primary hyperparathyroidism,
both
sorry,
will
to
be.
calcium will be high, correct? In
Yes.
secondary hyperparathyroidism, PTH will go up to increase the calcium, right?
Yes.
To hypocalcemia is the stimulus. So patient will be hypocalcemic, should be, and PTH will be elevated. And phosphate again, this action of PTH, the phosphate will be low. So normocalcemic hyperparathyroidism is a variant of primary hyperparathyroidism often detected during osteoporosis workup. PTH is elevated, calcium is within normal limits, often due to early disease or intermittent calcium levels. Rule out secondary causes like vitamin D deficiency, CKD before diagnosing. Even CKD, we will call it as a tertiary hyperparathyroidism, right? Yeah. Next question. A patient presents with lethargy and confusion. He has calcium 3.6, which is of course elevated, PTH low, phosphate high, vitamin D high. What is the most likely diagnosis?
Vitamin D toxicity.
Vitamin D toxicity. Why? Why do you think vitamin D is high? Very unlikely to get vitamin D toxicity. First of all, calcium is very high. I don't think vitamin D will cause. Again, if vitamin D is high, then PTH will also go. Yes, it's a stimulus to decrease the PTH. But what's happening here? Hypercalcemia is there, PTH is low, phosphate is high, vitamin D is also high. So more goes in favor of, I think it is primary hypertension is ruled out, meal alkali is ruled out, ectopic PTH is ruled out. So we left with vitamin D toxicity or sarcoidosis. Correct. So very high calcium, I think it will go in favor of sarcoidosis. Yeah. In granulomatous disease like sarcoidosis and TB, macrophages convert vitamin D into active vitamin D independently of PTH. Correct? High calcium plus suppressed PTH plus high active vitamin D is equal to extrarenal synthesis of calcium. Phosphate is often too high due to increased gut absorption, and vitamin D toxicity also shows high vitamin D, but usually from over supplementation, which is very unlikely. So that could be an answer, but still it's an unlikely choice in this scenario. Of course, there will be more, maybe in exam, there will be more clinical features pointing sarcoidosis or vitamin D toxicity.